Want to very quickly do the diabetes lecture. We need to take time. Really, this begins on slide 60 with a picture of the pancreas. So the pancreas, remember, is both an endocrine and exocrine organ. So you'll see that in cases of things like pancreatitis, which is inflammation of the pancreas, that you can have some endocrine disorders as well. So there is acute pancreatitis and chronic pancreatitis. Acute pancreatitis is inflammation of the pancreas because the duct through it has become blocked. Chronic is the same way, but it's usually due to more long-standing issues like heavy drinking. If you look at the picture on your slide, the pancreas is going to take over most of the upper left quadrant, and because it's in such close relation to the liver, when people are drinking high amounts of alcohol for long periods of time, hepatitis or alcoholic-related liver swelling can put pressure on the pancreas and block the duct. One of the things made by the pancreas is trypsin, remember, which digests proteins, so you can get a digestion of the physical cells of the pancreas. Every time there's a flare of acute pancreatitis, it damages a little bit more tissue, which can then become chronic. So you can either see these types of pancreatic issues, again, from an inborn endocrine error or because of damage due to pancreatitis. So just for review, pancreatitis is either caused by heavy drinking and hepatitis and alcohol-related liver swelling, or because of a manual blockade of the duct. So on slide 61, you have the endocrine cell portions of the pancreas called the islet of Langerhans. And the cell types that are important in this lecture are the alpha and beta cells. The alpha cells make glucagon, and then the beta cells make insulin. And insulin is very important to move glucose into cells. So the deal with insulin is that it is needed in order to physically move the glucose. So the only cells in the body that can bind glucose when they're at their resting potential include the beta cells in the pancreas, and then we have cells in the brain that can take up glucose at rest as well. The brain loves to run on glucose. Every other cell that utilizes glucose needs insulin to first bind to its receptor so that the glucose transporter can open. So if you don't have insulin, glucose can't really enter the liver cells, the muscle cells, the fat cells. Instead, it's going to stay in the bloodstream. So if you go to slide 62, you see our negative feedback loop with insulin and glucagon. This is another example of a physiologic feedback loop. So these hormones are only released in response to levels of glucose in the blood. So in states of high blood glucose, you'll see the beta cells of the pancreas make insulin. Those insulin portions, they bind to their receptors and change the resting membrane potential of the cell, allowing glucose transporters to open, so the glucose can then leave the bloodstream and go into the tissues that need it. In times of low blood glucose, like between meals, definitely overnight, you still need glucose to run the cells of the body, so glucagon will be released by alpha cells in the pancreas, and glucagon is used to liberate glycogen. It starts to drive glycogenolysis, the breakdown of glycogen, so that glucose is released into the bloodstream. On slide 63, you just saw Wilfred Brimley. You can enjoy him. And so 64, we go on to diabetes mellitus. Diabetes mellitus is the type of diabetes that involves not only polydipsia and polyuria and polyphagia, so excessive eating, but also a problem with insulin. And it falls into two categories. So the first one on slide 65 is called insulin-dependent diabetes mellitus, IDDM, or type 1 diabetes. And type 1 diabetes is thought to be an autoimmune disease. So nobody's really sure what causes the immediate development of antibodies. But what you see is the development of antibodies against the beta cells in the pancreas, and you end up getting beta cell destruction. If you do not have insulin-producing cells, that means you're going to be dependent upon an exogenous source of insulin for the patient's entire life. There's a lot of different ways to deliver that insulin, but primarily it has to be given through an injection. So insulin is one of these peptide hormones. It breaks down in stomach acid, so it cannot be given by any oral route. It has to be given by injection. The old name for this was juvenile diabetes, because you do see this developing towards the end of childhood, like ages 10, 12, 11. And the problem is insufficient insulin production. And when you're not treating it, you get very thirsty. So thirst matches urination. So lots of drinking, lots of urination, feeling very tired. The eyesight becomes affected. And eventually, as it progresses, you see some peripheral neuropathies that might lead to nerve damage in the feet. People lose a lot of weight. And when you're not burning glucose as a fuel, you shift to moving to a more ketoacidotic state, so you're burning ketone bodies, and eventually you see ketoacidosis develop, which is going to lead to a very kind of pleasant smelling fruity breath from the patient. So type 1, you can assume that these patients are going to be on some sort of insulin, and sometimes also an additional medication that is typically used to treat type 2 diabetes. With treating diabetes, when they're using insulin, it works really efficiently, and it's the same as what you would see what the body does. It's going to move glucose into cells, which means that you can have low blood sugar, most quite commonly as the number one side effect of this. So to try to avoid this, patients check their blood levels throughout the day of glucose so that they stay within range. So this used to be a rather invasive procedure involving pricking the fingers. That's what you see on the slide. And then eventually they moved on to glucometers. So in this picture, that takes a microscopic sample of blood, typically on the forearm where there's not as much nerve innervation, so you don't feel as much pain. Then what we can also do is, rather than having the patient inject the insulin, so it's typically injected into the abdominal fat, so the patient would have to take a fistful of abdominal fat and inject into it multiple times a day, depending on what their glucose levels are. So now we use an insulin pump. This is worn on the belt of the patient, on the pants of the patient, and they can turn their insulin levels up or down depending on their glucose readings if they're using it with a glucometer. I think I mentioned in class that Apple Health and some other tech companies have developed a system where the patient wears a patch on their arm. It almost looks like a nicotine patch, and that takes samples, microscopic samples of the blood throughout the day, tests it for glucose, and then sends that message to an app on their smartphone, which will then program the insulin pump to put out as much insulin as needed. So it's a really cool integrated system. And at the same time as that information goes from the insulin pump to the app, it sends that information to the doctor or endocrinologist, so everybody is getting a daily health readout of how that patient is doing. You can also have your family on your plan, so if you had a child with diabetes and you wanted to make sure they were getting the correct dose of insulin, you get everyone who you add to your family's readout too. So it's a really cool integrated system that's used now. On slide 67, we have our most common side effect. Because insulin works so efficiently, the number one thing that you'll see toxicity-wise is low blood sugar. Another thing I mentioned is that it has to be given by injection. You cannot give a peptide hormone by mouth. It degrades immediately in stomach acid. Even if you give it IV, it only has a 10-minute half-life, which means the best route of administration for insulin is subcutaneous. Another way to make subcutaneous injections last a little bit longer is to inject it into the adipose region. That will lengthen the time of the effect. On slide 68, you see type 2 diabetes. This is definitely not one that's associated with the use of insulin. So in most cases of type 2 diabetes, we see that the pancreas is working as hard as it can, but in some instances, the body outgrows its pancreas. The pancreas can only make so much insulin for so much body tissue. So if somebody overrides that through body weight or metabolic reasons, like in metabolic syndrome, it's a disease characterized by type 2 diabetes and obesity. You see that the pancreas is doing all it can, and it just cannot produce enough insulin for that body or for that person's diet, which might be high in carbohydrates or sugar. So kind of what you see in that picture. High carbohydrate sugar diet, lots of insulin release. And as time goes on, the body starts to either not respond to that insulin that's being reduced because of receptor fatigue, or the pancreas just can't make enough to supply the organism. So type 2 diabetes is more diet, lifestyle related, although there are a large amount of cases that we would consider idiopathic in nature, where we can't really pin down the reason somebody has type 2 diabetes. On all of the medication bottles that are used to treat diabetes, it says that changes to diet and exercise are not, or are more efficacious as a treatment to that person. So ideally, if you could clean up the diet from really high insulin spiking foods, so low carbohydrate intake, high protein intake, low sugar intake, those things will start to smooth out the levels of insulin release. And losing body mass is going to contribute to the pancreas being able to function as well. So type 1, type 2, this used to be called adult onset diabetes, but unfortunately we see this now developing in children, sometimes under 10, which is an interesting conversation about things like whether or not that constitutes child abuse, because at that point in time that children is not choosing their own foods. So that's a conversation that's been going on. You can think about that on your own. And also with type 2 diabetes, like you see on slide 69, these medications work really well also. So drugs like metformin, liraglutide, they all help lower blood glucose. And the balancing act is to try to keep blood sugar really in this nice window. So you don't want it to be too high and get hyperglycemia, and you also don't want it too low, like you see on slide 70 with this hypoglycemia. And when people have hypoglycemia, their head hurts, they get shaky, they're hungry, they're tired, they're weak, they start to sweat. That's very physiologically stressing to the body, so that leads to a sympathetic outflow. So we want to keep them within that nice narrow window. Just finally, the final type of diabetes is called gestational diabetes, and in gestational diabetes, there are high levels of blood glucose in the mother because now her pancreas has to make enough for both the fetus and herself, enough insulin. So if there's not enough insulin being created, the glucose will stay in the bloodstream and then it's stored in fatty tissue. So you'll see that these babies are typically heavier than normal weight babies because they're putting on extra fat. This develops in 1% to 2% of women with no history of diabetes, and it's taken pretty seriously because malformations arise in about 10% of newborns, and they can be pretty serious, like cardiovascular changes, neurologic abnormalities, spontaneous abortion, or early postpartum death. So it's serious. Most women receiving prenatal care are screened for gestational diabetes. This is something that's actually treated with insulin because the mother is just not making enough for herself and the fetus or fetuses, so we don't want them to get into hyperglycemic states. Okay, and on slide 72, we just have the chronic effects of diabetes. So over time, some things that occur, especially when it's not treated appropriately. So in all people, we see that small vessels change with aging. So microangiopathy is something you see even earlier on when patients have diabetes. The small vessels start to change and become a little bit more fibrotic. What that means is that we can have restriction of blood flow to certain areas, which can lead to things like ischemia. You definitely see that the arteriolar walls get larger. Because the vessels lack compliance, they're more likely to become damaged due to turbulent flow, meaning that cholesterol can deposit there, and there's atherosclerosis. I really want you to remember that relationship, especially for real life. Systemic hypertension is really, really prevalent in diabetes. 50% of those with diabetes, so 1 out of 2 have hypertension. And the leading cause of death in patients with diabetes mellitus is an infarct due to an atheroma. So it is very clinically relevant. You see these vessel changes, increased turbulent flow, increased plaque deposition, and then eventual ischemia and infarct. Also, when small vessels are changing, you see that blood's not flowing to the lower limbs. The healing doesn't go as appropriately. You see ischemia, necrosis, possible gangrene, sometimes dual amputation. And it's extremely important for patients with diabetes to do things like check their feet every day because you see a lot of neuropathy in the feet. So if you were to step on a piece of glass, you would feel it. You'd have a pain response, you'd move the glass, and that would hopefully be the end of the story. But if somebody is not checking their feet and they cannot feel their feet, it's likely that they might step on something and never take it out. And that leads to an infection and then eventually this necrotic gangrenous. That would be a dry gangrene type of issue. And once you get to dry gangrene, then you're looking at limb amputation. So encouraging good foot care is important, wearing slippers or at least socks in the house and just checking the feet every night. Diabetic nephropathy, so that's disease of the kidneys. There is something at the tip of the renal pyramids called papillae. It's kind of like the capstone of the pyramid. And renal pyramids are within the kidneys in the capsule, and they're there to collect filtrate to turn into urine. And it's kind of like the neck of a funnel is the best way to think about it. So in diabetes, patients develop necrotizing papillitis, where the papillae become inflamed and then they die off. And so if you lose the neck of a funnel, if you were to pour liquid through a funnel, there's no neck on it. The liquid's going to go everywhere. So what you see in diabetes is that the filtrate, rather than going and being shunted down the pelvis to the ureters, it enters the parenchymal tissue of the kidneys and starts to cause scarring and fibrosis and destruction. Also, when people use their kidneys a lot, so just overtax them like you do in diabetes because there's so much polyuria, you can also get damage to the kidneys that way. So kidneys and diabetes go together quite nicely. Cataracts and glaucoma, because you're getting these small vessel changes, the pressure goes up, they're less compliant. You could have small aneurysms develop, and if they rupture within the retina, that causes irreversible vision loss. So that's something that's very dangerous. Cataracts are common in older age, and they're more common with diabetes. Certain medications actually exacerbate them. And then definitely peripheral neuropathy. So pain, so that can be anywhere on the spectrum from numbness to the pins and needles, ischemia type of pains. And then eventually bowel and bladder dysfunction because of lack of nerve conductance. So it's really important to make sure your patients are being treated appropriately, taking the medications that they need. If they can comply with lifestyle changes, that's even better. Okay.